So the first specimen is 掰平衡一下，谢谢。So the first specimen is an ascites specimen. So on low power, it's hypercellular. A lot of them were inflammatory cells, as well as maybe some of them were mesothelial cells. And these type of tumor, sometimes I would think as one of the most difficult for the screener to identify. So the patient had a past history of pancreatic cancer. So usually the pancreatic adenocarcinoma will form this very small cell nest. So sometimes it's not very easy to identify just on low power view. But when you go to high power, these cell nucleus were all in different levels, and the cytoplasm are very bubbly. The nuclear definitely shows some atypia. And so this small tight cluster is compatible with pancreatobiliary primary adenocarcinomas. The morphology is very good for that. The problem is that the cellularity, the tumor cell is very, very scant, so it is not very difficult. It is not very easy to identify, so our screener is doing a very good job. And this is the cell blood preparation. Again, very scant. There's only one cluster with very similar morphology. So as you can see here, we do have a luminal border, very smooth. This smooth luminal border pattern. The cytoplasm is bubbly. So this is also compatible with the adenocarcinoma of pancreatobiliary primary. So we are getting more and more of these type of tumors because we are a large center for pancreatic cancer patients. So this is a different patient with also history of pancreatic adenocarcinoma. And this is also an ascites specimen. In this specimen, it is much easier because most of the cells are tumor cells. And with this very high-grade morphologic feature. So this one is not difficult to call this positive adenocarcinoma. So as you can see, the disease progress and the tumor become more poorly differentiated. So it forms more like individual single cells. So this is also positive. So a different patient, this is also from ascites. The patient has a pancreatic tumor, not pancreas, sorry, liver tumor, and it has been confirmed by biopsy that it is an adenocarcinoma, and likely it is a cholangiocarcinoma, which is the primary biliary tract adenocarcinoma inside the liver. So for this specimen, again, we do see a cell cluster with three-dimensional architecture. The nuclear polymorphism is very striking. We see cytoplasmic bubble, so forming a very tight small cluster. So this is also similar to the architecture pattern that we usually see in the pancreatobiliary tract adenocarcinoma. But this tumor is poorly differentiated, so we have these very high-grade nuclear feature make it very easy to be identified. Okay, so this is a cholangio with with peritoneal cavity metastasis. Another ascites specimen. Again, on low power, you start to identify this very small, tight cluster of cells. And you go to high power. Again, you show very similar morphology. And here you also see there are some mucin in the cytoplasm. So again, it looks like pancreatobiliary feature. with these like a tubule, small nest, some bubble in the cytoplasm. The patient had a gastric cancer. So majority of the time, the gastric cancer, if it goes to the peritoneal cavity, it's mostly will show the signaling cell morphology. But occasionally they are like a tubular pattern or intestinal pattern, gastric adenocarcinoma, and can rarely metastasize to the peritoneal cavity. And this is the morphology will be very similar to the pancreatobiliary tract adenocarcinoma. Okay, so this has a very similar morphology to the pancreatobiliary tract cancer, but this is coming from the gastric primary. So the other common specimen that we have, so moving to the pleura cavity. So this is a new patient in the pleura cavity with a lot of these large glandular cells and with these hobnailing feature of the lumen, vesicular chromatin prominent nucleolus. So this is compatible with primary lung adenocarcinoma. Because this is a new patient, we will do a TTF1 on the cell block preparation. So this is the cell block. So after we confirm that the cell blocks, the tumor cells are positive for TTF1, they will use these specimen for EGFR molecular testing. Yeah, the second patient is also coming from the pleura effusion, but the patient already had a confirmed history of lung adenocarcinoma, and she's currently under the treatment. So this is compatible with the recurrence or resistance of the disease. So with very similar morphology. So this is also a lung adenocarcinoma. So finally, there is a quite like unusual case. Pleura effusion coming from a 50-year-old female. So in this specimen, on low part, we see a lot of single cell. We do not identify like obvious cell cluster or like a three-dimensional architecture. So we go to high power. We have a lot of these single cells. Some of them do show cytologic atypia. It's forming like a very vague signaling cell pattern, but it is not very like a definite for a signaling cell feature. So we see like a very scatter of cell. We show this big nucleus, prominent nucleoli, irregular nuclear membrane, and this looks highly suspicious for adenocarcinoma, but it doesn't form a very good architectural, like a cohesive pattern. So this is kind of difficult. So we go back to the history. She actually had the history of breast cancer, but it is ductal carcinoma, not lobular carcinoma, 2 years ago. And in the lung, there is carcinoma in situ, so it doesn't go to the pleura cavity because it is in situ cancer. So it's a little bit difficult to determine what exactly these tumor cells are. I think this is positive, but the morphology is very unusual. So we go to this cell block to see if we can identify some more architectural pattern, but again, in the cell block, it all looks very similar. Just single cells with nuclear polymorphism, and that's it. So at this point, I think we will rely on the immunohistochemistry. So first of all, because She had the confirmed history of 2 different cancer. One is from breast. Her breast cancer 2 years ago were positive for TRPS1, so we would do a TRPS1. For the lung, it is in situ, but we need to rule out the possibility of invasive cancer. So we would also do a TTF1 because this is a pleura effusion specimen. And if both negative, we will still need to check this is epithelial origin. So we would do an MOC31. So I ordered 3 different immunohistochemistry for this case. Basically, when we see something like this, we might need to consider these as we need to work it up as a new patient. So could it be a gastric cancer? Go to the pleura effusion. It is also possible. But if it's a gastric cancer, we won't be able to have any positive lineage marker. But we expect that most of these cells will be positive for MOC31. Even though the smaller one, the larger one, they all looks very similar. So you see more prominent signaling cell feature here in the cell block preparation. So confirm the epithelial origin, confirm the lineage, the primary site. This is our job to do. So here is another case. Pleura effusion, but with a history of pancreatic cancer. So for this specimen, we only see scattered, very bizarre cells. So individual high-grade cells with very bizarre-looking nucleus. So these are positive for adenocarcinoma, but because these already become very poorly differentiated, it's not easy to tell by the morphology where it is coming from. But we are certain that this is positive. So this is a poorly differentiated adenocarcinoma and compatible with the history of the pancreatic cancer. So let's move to some funny dot aspiration. This is thyroid aspiration. So on low power, first of all, we identified it seems to be a cystic background. So we do see some histiocytes, but we do not see a lot of like background material, and we don't see a lot of colloid material as well. So only the histiocyte, not blood, not colloid. And then we start to see some more of these follicular cells. So these follicular cells are slightly enlarged, forming these microfollicular pattern. So the nucleus does show enlargement and a little bit of nuclear irregularity. So it does have some nuclear atypia. However, the atypia does not like strike you with the nuclear feature of a PTC. So this is more in line with a RAS-like atypia with just like a enlarge of nucleus with like a very subtle like irregularity of the membrane. So because of these prominent microfollicular pattern and the enlargement of the nucleus, I think this is reasonable to consider these as a follicular neoplasm. So currently for the follicular neoplasm, we allow to have a mild degree of nuclear atypia because RAS positive tumor can have nuclear atypia. And in the WHO classification, we also have the NIFP. NIFP can also have the nuclear atypia. very similar to the PTC, but not definite for the PTC. So because of these microfollicular pattern, it's better that we classify these as a follicular neoplasm. So the patient, if they want to have surgery, the most appropriate procedure would be just a single lobectomy. If you call these suspicious for PTC based on these degrees of nuclear atypia, the clinician might go ahead to do a total thyroidectomy, and it might be just over-treatment for the patient. So for this case, we call these suspicious for follicular neoplasm. It's TBS category 4. And the clinician can determine if the patient wants to do a surgery or not, and discuss with the patient. So the next specimen is coming from a lymph node. On low power, we see hypercellularity. We do not see any. We do not see prominent lymphoid tissue, but a tight cluster of looks like epithelial nest. Just on these very low power, you already identify. We do see a lot of multinucleated giant cells. Okay. So we see multinucleated giant cells. We see epithelial nest, and the epithelial nest with nuclear feature very similar to papillary thyroid carcinoma, because you start to see more prominent like an oval shape of the nucleus, some with a little bit grooves. So remember, this is from the lymph node, so this is likely the metastasis of the papillary thyroid carcinoma to the neck lymph node. So we go ahead to check the history. The patient actually haven't received any surgery. He was diagnosed with PTC from the thyroid at the outside hospital and want to come to our hospital for surgery. So the reason that the clinician checked the lymph node is because they want to know if the patient would need neck lymph node dissection. So apparently the tumor already spread out of the central compartment. This is a lateral lymph node. So the patient would need the lateral lymph node dissection. So we call this positive and carcinoma compatible with metastatic papillary thyroid carcinoma. And some area you can possibly see the nuclear inclusion. There is a very vague one over here. Yep, so this is PTC in the lymph node. Finally, there is a pancreas US guided aspiration. This one is relatively difficult. So in the background, we see a lot of necrosis, necrotic debris. So we know this might be something wrong. We do identify some like a more viable epithelial cells. These cells show quite high NC ratio and with a vague glandular feature. But the morphology, I would say the NC ratio is very high, so it's a little bit different from what we expect for the usual adenocarcinoma of the pancreas. Usually we will see more commonly to have cytoplasmic mucin, or at least some of the cytoplasm, not these very high NC ratio feature. So we go to the direct smear. The direct smear show a lot of like degenerative cells, and with these like atypical nucleus, very high nuclear NC ratio, and the chromatin pattern seems to be a little bit, to me it's a little bit salt and paper. So it's kind of weird, and it's quite easy to see these like crashing artifacts. So it got a little bit of small cell feature because of this very high NC ratio, and I did not see any prominent nucleolus. However, it's the arrangement. Some of the cells still seems to arrange in a glandular feature. So this is kind of weird. So we go back to the history. It is an elder male patient. He has been smoking for a long time, but quit it at the age of 59. I think he is currently 71. And he has been confirmed with lung adenocarcinoma in the pleura effusion. And we do perform TTF1, it is positive. So I go back to the pleura effusion specimen to see the morphology. The adenocarcinoma actually looks very similar like this. So without any nucleus, without any nucleola, and the chromatin pattern is very diffusely homogeneous, just looks like this, and with a relatively higher NC ratio, so it looks very blue. So this is likely a metastatic lung cancer to the pancreas instead of the primary pancreatic adenocarcinoma. So these, you also see this molding type of pattern. So it looks really like small cell carcinoma. But again, the architecture pattern in the pleura effusion suggests it is the adenocarcinoma. I think Dr. Gao, he got the core needle, the EUS biopsy also show glandular feature, but just the nucleus is relatively unusual for the usual lung or pancreas adenocarcinoma that we see, possibly because the patient is a heavy smoker. So this is possibly not a tumor drive by the EGFR. We don't know. Yeah. So this is more likely to be adenocarcinoma metastasis from the lung instead of pancreatic primary. So we call this carcinoma. Okay, that's it for all the case today.